Imagine a single pill that can, stop a life-threatening brain seizure in a matter of minutes.
Right. It's a medical marvel.
But then imagine that abruptly stopping that exact same daily pill can actually cause a lethal seizure.
Yeah, it really is a profound paradox.
I mean, it's
Like,
crazy.
you have the ultimate cure for an acute crisis, right? And then the potential cause of that exact same crisis just wrapped up in the identical chemical structure.
And that contradiction, that is the mission for our deep dive today. We're exploring the fascinating pharmacology of benzodiazepines.
Which are literally everywhere.
Oh, totally everywhere. If you open a few random medicine cabinets in your neighborhood, you are almost guaranteed to find one.
Yep.
So we want to figure out how they provide such incredibly fast relief for severe anxiety and seizures. And we're going to unpack their totally unique mechanism in the brain, specifically how they work with a chemical called GABA.
Right. The GABA system is key here.
Exactly. And finally, we need to navigate the very, very messy history of their dependence risk.
Well, to really ground this, we should probably start with what a benzodiazepine actually is.
Yeah, let's do that. Because the name is a mouthful.
It is, but it just describes the molecule's physical architecture. It's a specific chemical skeleton.
Like a structural blueprint.
Exactly. You have a benzene ring, which is a hexagon of carbon atoms, and it's physically fused to a seven-sided ring called a diazepine ring.
Hence, benzodiazepine.
You got it. And that framework is the literal key that unlocks their effects. In a clinical setting, you'll hear them called anxiolytic sedative hypnotics.
Which is such clunky medical jargon.
It really is. And it undersells their range. Depending on the specific molecule and the dose you take, I mean, they can reduce panic, knock you out for sleep, break a seizure, relax skeletal muscles,
Oh, okay.
and even cause anterograde amnesia.
Wait, anterograde amnesia, let me make sure I have that right. That means you lose the ability to form new memories going forward. Like, while the drug is active in your system.
That's the one. Your brain basically just stops hitting the record button.
Which sounds like an absolute nightmare if you're, just trying to get through a stressful Tuesday at the office.
Oh, absolutely a nightmare. But imagine you are about to undergo a really uncomfortable medical procedure.
Okay, like what?
Say an endoscopy or a complex dental surgery. You want to be relaxed, compliant, and most importantly, you do not want to remember the trauma of the procedure afterward.
I see.
Right. In that specific context, anterograde amnesia is a feature, not a bug.
Okay, let's unpack this, because that makes total sense. But how did we even find a chemical skeleton that does all of these incredibly specific things?
It's a wild story, honestly.
Because I always assume these blockbusters are the result of some billion-dollar, decades-long master plan by a pharmaceutical giant.
I mean, usually yes, but in this case, the most culturally impactful psychiatric drug of the 20th century was essentially the result of a lab assistant doing some spring cleaning.
You're kidding? A housekeeping accident.
A literal shelf-cleaning exercise.
That is wild.
So, the story takes us back to a Polish-born chemist named Leo Sternbach. In the 1950s, he was working for the pharmaceutical company Hoffman-La Roche in New Jersey.
Okay, New Jersey, the 50s. Got it.
Right. And years earlier, he had studied a class of chemical dyes called benzheptoxydiazines.
Okay.
He had this hunch that if he tinkered with their structure, he might find something pharmacologically useful. So between 1954 and 1955, he synthesizes dozens and dozens of variations.
Hoping for a breakthrough.
Yeah, but every single one was a total dud.
Oh,
They
yeah.
did absolutely nothing in animal testing.
So he just shelves the project and moves on.
He moves on entirely. One specific compound from that failed batch gets put on a shelf and just sits there collecting dust for 2 years.
Wow.
Then, in April 1957, his lab assistant, Earl Reeder, is cleaning up the workspace.
Doing the spring cleaning?
Exactly. He finds this dusty old vial. And instead of just throwing it in the trash, which, would have been the logical thing to do with a failed experiment,
Right, you toss it.
he decides to send it off for one last routine pharmacological screening.
That is mind-blowing. Imagine if he just tossed it.
Right.
The entire landscape of modern medicine changes because he decided to run one more test.
It's incredible. The results came back from the animal testing lab, and they were unlike anything Roche had ever seen.
Really? What did it do?
The compound was a remarkably potent sedative and muscle relaxant. It calmed the animals down without completely anesthetizing them.
Which was the holy grail back then, right?
Exactly. That quote-unquote failed compound became chlordiazepoxide.
But I want to pause on the context of the 1950s here.
Sure.
Was Roche just lucky to stumble on this, or was there a massive, desperate void in medicine for a drug like this?
Oh, there was a massive void.
Because when you look at how people treated anxiety and insomnia before 1957, the options were frankly terrifying.
The medical world was desperate for an alternative. To understand the explosion of benzodiazepines, you really have to look at the drugs they were replacing.
Right, the barbiturates.
Exactly, the barbiturates. We're talking about drugs like phenobarbital.
Okay.
Barbiturates had been the dominant sedative since the early 1900s, but they carried a terrifyingly narrow therapeutic index.
Meaning the margin of error between a dose that helps you get a good night's sleep and a dose that permanently stops your lungs from working is incredibly small.
Razor thin.
Yeah.
Literally a few pills difference. Because of that narrow margin, barbiturates were heavily involved in fatal overdoses.
Yeah.
They were the primary method for suicides during that era, and they produced a severe, often fatal withdrawal syndrome if you stopped them abruptly.
So they were incredibly dangerous.
Very. So when Roche brought Sternbach's accidental compound to market in 1960 under the brand name Librium,
Librium, right.
they didn't just market it as a sedative, they explicitly positioned it as the safe alternative to barbiturates.
And was it?
Objectively, when it came to lethal overdoses, yes, it was vastly safer.
And Sternbach didn't stop with Librium, right? He kept modifying that chemical skeleton.
He did.
And in 1963, Roche released diazepam, which the world knows as Valium,
The big one.
the huge one. Valium didn't just become a successful medication, it became a cultural phenomenon. It was the best-selling drug in the United States for years.
It's hard to overstate how popular it was.
Right. By 1978, Americans were consuming 2.3 billion Valium tablets annually.
Billion. With a B.
It was so embedded in the culture that the Rolling Stones wrote Mother's Little Helper in 1966.
Oh yeah, a song directly calling out housewives relying on these little yellow pills to cope with the daily grind. The scale of that adoption is staggering. But, it brings up a really massive question.
So what's that?
If this drug was taking over the world, why was it so much safer than the barbiturates it replaced?
That is the big question.
How could a drug be powerful enough to knock you out, but safe enough that it was incredibly difficult to fatally overdose on it?
Right. How does it physically do that?
To understand that, we have to look at your brain cells and a mechanism called allosteric modulation.
Allosteric modulation. That sounds like a concept that requires a deep dive into the brain's GABA system.
Let's break it down. So gamma-aminobutyric acid is the primary inhibitory neurotransmitter in the mammalian brain.
Inhibitory meaning it slows things down.
Exactly. Its entire job is to calm your nervous system down. It's the natural counterbalance to excitatory chemicals, like glutamate, which fire your brain up.
So if you are having a panic attack or a muscle spasm or a brain seizure,
Yeah.
that is essentially your neurons firing excessively or chaotically.
Right.
And GABA's job is to step in and restore order.
That's the core of it. GABA works by binding to a specific protein on the surface of your neurons called the GABA-A receptor.
Okay, I'm picturing it.
Think of this receptor like a microscopic gate. When natural GABA binds to it, the gate opens and chloride ions rush into the neuron.
Chloride ions.
Yes, and because chloride carries a negative electrical charge, it floods the cell with negativity.
Which does what?
It makes it much, much harder for that neuron to fire off an electrical signal. It quiets everything down.
Okay, let me try an analogy here to see if I'm tracking.
Go for it.
If your nervous system is a car, and a panic attack is that car speeding out of control, GABA is the driver stepping on the brake pedal.
I like this, yes.
And the barbiturates, the old dangerous drugs from the 1950s, they act like a passenger reaching over and slamming the brake pedal down themselves, regardless of what the driver is doing.
Spot on. That passenger can push the pedal all the way to the floor and stop the car entirely.
Meaning they stop your breathing.
Exactly. Barbiturates can force that chloride gate open all by themselves at high doses. They completely bypass the brain's natural control systems.
But the benzodiazepines, they don't press the brake pedal at all.
No.
They just give the driver power steering.
Yes.
They make the brake pedal incredibly sensitive.
Yeah.
So when the driver naturally presses it, the car stops immediately.
That is a brilliant way to visualize allosteric modulation.
Oh, awesome.
Because benzodiazepines, they do not bind to the same keyhole as GABA. They bind to a completely separate adjacent site on that exact same receptor complex.
Oh, interesting. So they don't block GABA.
Right. By locking into that adjacent site, they subtly twist the physical shape of the receptor.
Yeah.
And that shape change makes the receptor intensely sensitive to the natural GABA that is already floating around in your brain.
So the gate opens wider and more frequently, letting in more of that calming chloride. But only if your natural GABA is actually there to turn the key.
Exactly. That is the crucial safety mechanism. A benzodiazepine does absolutely nothing on its own if GABA is absent.
Wow.
It is purely an amplifier. This creates what pharmacologists call a ceiling effect.
A ceiling effect.
Yes, because there is a hard limit on how much natural GABA your brain produces at any given moment. There is a hard limit on how much a benzodiazepine can depress your central nervous system.
Which perfectly explains why they don't cause fetal respiratory arrest on their own.
Exactly.
Take too many barbiturates, they smash the gate open, you stop
Mhm.
breathing. Take too many benzos alone, they amplify your natural GABA to its absolute limit. You fall into a deep sleep, but your brainstem keeps telling your lungs to breathe because the ceiling holds.
The safety profile was an absolute revolution in medicine.
Here's where it gets really interesting, though, because this functional definition has expanded today, hasn't it?
Oh, definitely. You've probably heard of the Z drugs.
Yes. Medications like zolpidem, which is Ambien,
Mhm.
or azopiclone, which is Lunesta,
Yeah.
the modern sleeping pills.
Exactly.
Are those technically benzodiazepines?
Chemically, no. They don't have that fused ring skeleton we talked about earlier.
Okay.
But functionally, they bind to that exact same power steering site on the GABA-A receptor.
Ah, so the mechanism is the same.
Virtually identical. Because of that, clinicians and regulators treat them with the same caution regarding how they work and their risks for dependence.
So we have this incredible mechanism, this power steering for the brain's calming system. Let's look at how that actually plays out in a medical emergency.
It's pretty amazing to see.
Because this mechanism translates into unparalleled clinical power when every second counts.
There is perhaps no better arena to see this power than in treating status epilepticus.
Okay, what is that exactly?
It's a profound medical emergency. It's defined as a seizure lasting more than 5 minutes, or repeated seizures where the patient doesn't wake up in between.
And when your brain is seizing for that long, it's basically an electrical storm.
A massive one.
It's burning through oxygen and glucose at an unsustainable rate.
And it's rapidly destroying tissue. Prolonged status epilepticus can cause permanent, irreversible brain injury.
So you have to stop it. Yes, asked.
You have to stop the neuronal firing immediately. Intravenous lorazepam, which is a powerful benzo, has long been the gold standard. But imagine you are a paramedic.
Cool.
You arrive at a house, the patient is on the living room floor, convulsing violently, trying to find a tiny vein and successfully start an IV line on someone who is actively seizing.
That sounds like a logistical nightmare.
It's nearly impossible.
Which brings us to the Rampart trial from 2012. I remember reading about this in the source material. It completely upended how emergency responders handle seizures in the field.
It changed everything. The Rampart trial was a massive study comparing that difficult 5E method to something much simpler, an auto-injector.
Like an EpiPen.
Exactly like an EpiPen. They equipped paramedics to just take a different benzodiazepine midazolam and shoot it straight into the patient's thigh muscle.
Bypassing the vein entirely.
Exactly.
But does it act fast enough? Because muscle absorption is usually slower than IV.
It acts incredibly fast. The trial proved that intramuscular midazolam was just as effective at stopping the seizure before reaching the hospital as trying to get IV access.
Wow.
The drug gets absorbed from the muscle, crosses into the brain, hits those GABA receptors, and turns on the power steering.
And the electrical storm just stops.
The storm stops. It revolutionized pre-hospital care because it removed the friction of finding a vein.
That is the ultimate emergency brake. But seizures aren't the only acute crisis. What happens during severe alcohol withdrawal?
Oh, that's another critical use.
Because my understanding is that benzos are essentially the only safe way to get someone through that detox.
They are the standard of care, and the neurology behind why is fascinating. Alcohol, much like benzodiazepines, is a GABA receptor modulator.
Oh, really?
Yeah. If you are a chronic, heavy drinker, your brain is constantly flooded with this artificial calming signal.
Okay, so the brain is being artificially quieted all the time.
Right. Now, the brain hates imbalance. To try and stay awake and functional, it physically adapts.
How so?
It downregulates its own inhibitory system. It essentially removes GABA receptors and turns down its natural sensitivity to fight off the sedation of the alcohol.
I see. So the brain is constantly flooring the gas pedal just to maintain a normal speed against the alcohol's brakes.
Precisely. Now, imagine that person suddenly stops drinking.
Cold turkey.
The alcohol's gone, but the brain's gas pedal is still floored. That heavy compensation is suddenly unmasked. The brain is left massively underinhibited.
Which causes what?
This chaotic electrical overdrive produces severe tremors, agitation, hallucinations, and in the worst cases, delirium tremens and life-threatening seizures.
So you use a benzodiazepine to step in and replace the alcohol.
Yes. Because benzos act on that exact same GABA receptor system, you are substituting an incredibly messy, uncontrollable drug alcohol with a pure, precisely measurable pharmaceutical.
That makes perfect sense.
Hospitals use a specialized symptom checklist called the CIWR scale. They monitor the patient's heart rate, tremors, and anxiety.
And dose accordingly.
Exactly. They dose the benzo based exactly on that score to gently ease the brain back down to baseline.
That brings up a crucial logistical question, though. If you were treating a seizure in an ambulance, or alcohol withdrawal in the ICU, or just giving someone a pill for a panic attack,
Right.
are all of these benzodiazepines interchangeable? Like, could a doctor just swap out Xanax for Valium?
That is a very dangerous misconception. They are absolutely not interchangeable. While they all twist the same receptor, they behave vastly differently in your body, primarily in their half-life.
And the half-life is the amount of time it takes your liver to clear half the drug from your bloodstream, right?
Exactly.
Walk us through the extremes. How different can they actually be?
Well, let's look at alprazolam, heavily marketed as Xanax. It has a relatively short half-life, roughly around 11 hours.
Okay.
It hits your system fast, provides immediate relief, and leaves fast.
Sounds ideal for a panic attack.
It is, but that rapid exit creates a problem. Rebound anxiety. As the drug washes out, the brain senses the drop and the anxiety spikes back up, often worse than before.
Oh, man. Urging the patient to take another pill.
Exactly. It's a tricky cycle.
Okay, so that's the short-acting side. What about the long-acting side?
Let's look at diazepam, or Valium. Valium has a fascinating quirk. When your liver breaks it down, it doesn't just eliminate it.
What does it do?
It actually converts the Valium into several new compounds called active metabolites. The most notable one is called desmethyldiazepam.
Wait, so your body is essentially manufacturing a different benzodiazepine inside your liver?
Yes, it's wild, and that metabolite has a staggering elimination half-life.
How long are we talking?
It can stay active in your system for 30 hours, up to over 100 hours, especially in elderly patients who naturally process drugs more slowly.
Over 100 hours. That means if my grandfather takes a single Valium to sleep on Monday night, that drug is still actively depressing his central nervous system on Thursday afternoon?
Exactly, and that has massive real-world implications. If you are an older adult, that lingering compounding sedation drastically increases the risk of severe falls.
The hip fractures.
Hip fractures, car accidents, days after you took the pill.
Wow.
But clinically, that long half-life is incredibly useful for one specific task: tapering.
Getting people off the drug.
Yes. If a doctor is trying to wean a dependent patient off benzos, they almost always switch them to a long-acting drug like Valium. It provides a slow, smooth descent, rather than the jagged, jarring withdrawal of something like Xanax.
Which brings up a massive contradiction. We've established this elegant mechanism. We know they have a safety ceiling. We see how they save lives in the ER.
Right.
So how did we end up with congressional hearings, Betty Ford's public crisis, and FDA black box warnings? Where does the safety net fit?
No, the narrative really shifts here from acute safety to chronic danger.
I want to start with the history of how they were marketed, because people were explicitly told these pills were not addictive, right?
They were. The original marketing aggressively pushed the label non-habit forming.
How do they justify that?
The prevailing theory at the time was that because benzodiazepines didn't produce the intense euphoric high associated with opioids or heroin, they couldn't be addictive.
But the body doesn't need euphoria to build a tolerance.
Not at all. Physical dependence on a benzodiazepine happens remarkably fast.
Even without a high.
Exactly. The brain adapts to that power steering being there every single day. Within just a few weeks of daily use, the brain alters its receptors.
Just a few weeks.
Yeah. By the late 1970s, the non-habit forming myth collapsed spectacularly in public view. In 1979, U.S. Senator Edward Kennedy chaired highly publicized congressional hearings specifically investigating Valium dependence.
Wow.
Everyday people testified about being prescribed the drug for years for mild stress, only to experience absolute agony when they tried to stop.
And that was right around the time former First Lady Betty Ford went public with her own severe dependency, right?
Yeah.
On a mix of alcohol and benzodiazepines.
Exactly. It shattered the illusion that these were harmless lifestyle pills. It forced a profound reckoning in the medical community.
And the true depths of that dependency were really documented by Dr. Heather Ashton, right? A British psychopharmacologist.
Yes, at Newcastle University. Throughout the 80s and 90s, she ran a specialist clinic dedicated entirely to helping people get off these drugs.
And what she found was that the withdrawal wasn't just, a few days of feeling jittery.
Oh no. She documented a nightmare scenario known as protracted withdrawal syndrome.
What does that look like?
She was treating patients who had successfully tapered off the medication, yet they were still suffering debilitating symptoms. Profound cognitive fog, relentless ringing in the ears, muscle spasms, and terrifying panic attacks that persisted for months and sometimes years after their final dose.
Years. The drug is chemically gone from their blood, but the brain is still in a state of chaos.
Because the architectural changes to the receptors take an incredibly long time to reverse.
That is terrifying.
Dr. Ashton created the Ashton Manual. It remains a landmark clinical protocol today. It outlines an agonizingly slow, fractional tapering process.
Substituting long-acting benzos and dropping the dose by minuscule amount.
Over months, yes. Because, as we touched on at the beginning, abrupt withdrawal from a high dose of benzos isn't just uncomfortable, it can trigger fatal seizures.
But wait, if they have a safety ceiling, why are they involved in so many fatal overdoses today?
Yeah.
You look at the statistics, and benzos are everywhere in the overdose data.
That is the most dangerous modern reality. Benzodiazepines rarely kill you if taken entirely alone.
Okay, if alone.
The danger is that they are almost never taken alone in an overdose scenario. The safety ceiling only exists if the rest of your brainstem is functioning normally.
So what happens when you mix them?
If you combine a benzo with alcohol, or, crucially, with an opioid painkiller like oxycodone or fentanyl, you completely annihilate that safety ceiling.
Why?
Opioids and alcohol suppress the breathing center in your brainstem through entirely different pathways. When you layer a benzodiazepine's GABA enhancement on top of an opioid's respiratory depression,
The ceiling breaks.
your brain simply forgets to tell your lungs to breathe. It is a catastrophic synergy.
Combination is what kills.
Yes. The medical system spent years co-prescribing opioids for chronic pain and benzos for sleep or muscle spasms.
Oh, man.
That specific combination drove such a massive, horrifying spike in overdose deaths that in 2016, the FDA took emergency action.
They issued a black box warning.
Their most severe, absolute, highest level alert, specifically targeting doctors, warning them against co-prescribing these two classes of drugs.
We also have to mention another dark application. That amnesia effect we discussed earlier, the one that's useful in a dental chair, has been weaponized.
Yes, it has.
There is a dark history of intentional misuse, most infamously with flunitrazepam, which most people know as Rohypnol.
Yeah. Rohypnol is a highly potent benzodiazepine that was actually never approved for medical use in the United States. In the 1990s, it became globally notorious as a date rape drug.
Right.
Predators exploited the exact pharmacology we outlined. It causes deep, rapid sedation and profound anterograde amnesia.
Leaving victims entirely unable to remember the assault.
Exactly. The crisis was so severe that in 1996, the U.S. passed the Drug-Induced Rape Prevention and Punishment Act.
And they changed the pill itself, didn't they?
They did. They forced the manufacturer to physically reformulate the pill, adding a blue dye so that if it was slipped into a clear drink, it would be instantly visible.
So, synthesizing everything we've just explored, we've gone from the accidental miracle drug of the 1960s to congressional hearings, brutal withdrawal syndromes, and FDA black box warnings.
It's quite a journey.
Where does that leave us today? What does this all mean for modern use?
The modern clinical consensus, guided by organizations like the American Psychiatric Association and the UK's NICE guidelines, is that our definition of what these drugs are for has drastically narrowed.
So no more mother's little helper.
Exactly. The era of the everyday tranquilizer, handing a patient a daily prescription for years to manage general life stress, is universally condemned.
The risks simply outweigh the benefits for chronic daily use.
Absolutely. Today, they are viewed as irreplaceable but strictly temporary tools. They are the emergency brake.
Use them for short-term symptom control.
Right. You stop the acute panic attack, you safely navigate the dangerous alcohol detox, you halt the emergency seizure, and then you get the patient off the medication as quickly as safely possible.
And if you are listening right now, understanding this context is incredibly important for your own healthcare.
Very much so.
Because despite everything we now know about protracted withdrawal and dependency, benzodiazepine prescriptions in the United States actually doubled between the late 1990s and the mid-2010s.
Which is staggering.
Recognizing the razor-thin line between a life-saving emergency intervention and a profound long-term dependency is vital for anyone stepping into a doctor's office.
It all comes down to deep, informed consent. Patients need to understand that the pill providing immediate, miraculous relief today is actively rewriting the architecture of their brain tomorrow.
Which leaves us with one final, frankly haunting concept from the neuroscience research to mull over.
Oh, the kindling effect.
Yes, we've talked about how the brain adapts to the drug and the chaos of withdrawal. But what exactly is kindling?
Kindling is a fascinating and sobering concept. It describes how repeated cycles of withdrawal, say, someone going on and off a benzodiazepine multiple times over the years, or repeatedly going through alcohol detox, progressively lowers their baseline seizure threshold.
Wow.
With every single cycle, the brain becomes more sensitized. Each subsequent withdrawal is statistically more severe, more difficult, and more dangerous than the last one.
Which forces us to ask a really uncomfortable question. If every single withdrawal cycle physically alters the brain's safety threshold, does the brain ever truly hit the reset button after chemical dependence?
That is the million-dollar question.
Or is a permanent, hidden memory of that dependence always left behind, wired deep into our neural circuitry, just waiting in the dark?
It's chilling to think about.
It brings us right back to the paradox we started with. A drug powerful enough to save your brain from a seizure today might just permanently rewire it to cause one tomorrow.
It is the perfect medical paradox, right down to the last neuron.